Welcome to our orthopedics webinar series. My name is Sarah Hibner, and on behalf of Premier Health and Premier Health's orthopedic specialists, I'd like to thank each of you for joining us this evening. We are so glad to have you with us. Tonight, we are here to discuss knee pain. As you may know, knee pain is a common issue for many. You are not alone. The good news is there are options available to help reduce your pain, increase mobility, and get you back to the activities you love. Our physician expert, Dr. Eric Fester, will give a brief presentation this evening on those options. He will also answer some of your questions following his presentation. So let's start off the evening by introducing our speaker. Eric Fester, MD, graduated from United States Air Force Academy and attended medical school at the Uniformed Services University of Health Services in Bethesda, Maryland. He completed an internship at David Grant Medical Center at Travis Air Force Base in California and residency in orthopedic surgery at Wilford Hall Medical Center at Lackland Air Force Base, Texas. In addition, he has an orthopedic sports medicine fellowship from Cincinnati Sports Medicine and Orthopedic Center. Dr. Fester is a diplomat and fellow of the American Academy of Orthopedic Surgeons and is a member of the American Orthopedic Society of Sports Medicine. He maintains office hours at Premier Orthopedics offices in Beaver Creek and Centerville. Dr. Fester practices at Premier Orthopedics, one of the largest and highly trained orthopedic and sports medicine practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery where needed, including minimally invasive arthroscopic and robotic arm knee procedures. With nearly 30 doctors and more than 12 locations, Premier Orthopedics is ready where and when you need help. Thank you, Dr. Fester, for being with us this evening, and I will turn the presentation over to you.
Thank you very much for that introduction, and welcome everyone. I am so glad you are here. Okay, let's get started. So we're going to discuss joint pain, and we'll focus on the knee. We'll discuss how we make that diagnosis, how we treat it both surgically and non-surgically, and then end with questions. So just broad picture here. A common causes of joint pain. Well, acute injury, so obviously sudden fall leading to sudden knee pain, but there's other overuse injuries for repetitive injuries over time, and there's also some conditions such as rheumatoid arthritis or psoriatic arthritis that are medical causes of joint pain. Joint pain can affect any joint. We're going to concentrate on primarily the knee this evening. There are a number of reasons to have knee pain. Basically all the anatomic structures that really are at any joint: tendons, bursas leading to bursitis, muscle strains, ligament sprains or tears such as ACL tears. There's supporting tissue problems specifically in the knee, that's meniscus tear. And then especially tonight, we're going to focus on focal cartilage lesions and osteoarthritis. Brief anatomy lesson. All joints are where two bones come together, and all of our joints are basically capped with cartilage. So articular cartilage is what covers the end of the bone. And then in between the two bones is joint fluid. So I tell my patients it's like ice on ice with water in between. A normal joint is very slippery and smooth and doesn't hurt. So when do things go wrong? Well, specifically, again, cartilage lesions, what this is kind of mainly going to focus on tonight. A focal cartilage lesion is just an isolated area of damage. And this is a very small area, typically about the size of a dime, or a lot of times even smaller than that. And I tell people this is like a pothole in the road. Just that one area of the road, the pothole is damaged. The rest of the road is okay. That's a focal cartilage lesion. Versus osteoarthritis, also known as degenerative joint disease, also known as primary osteoarthritis, is global cartilage damage. The whole joint has been damaged. This isn't just a pothole in the road. The whole road is rough. This is a focal cartilage lesion. So this is the end of the femur or the thigh bone, right at the knee joint. This is normal cartilage around it, nice and smooth and white. And then you can see this big pothole down to bone. Versus osteoarthritis. So sorry about this, isn't the best picture, but this is a normal knee over here on the left of your screen. To the right is where the entire end of that femur is damaged. The cartilage is just worn down everywhere. Again, just a bumpy road versus just a pothole. What are the symptoms of these problems? Well, pain in your joint is the most common presentation that we see, but it can be stiffness, it can be swelling, it can be what we call mechanical symptoms such as clicking, catching, or popping. How do we make the diagnosis? Well, we'll take a history, we'll examine you, of course, and then we'll go on to studies. X-rays is the first line of any joint. If it's a focal cartilage lesion, a lot of times it's not involved the bone, and so the X-rays will be normal. Then we'll go on and order an MRI. Versus if it's osteoarthritis, usually that will have bone damage as well, and that we'll see that on X-rays. Focal cartilage damage. Again, on the left here is a normal joint with normal cartilage. X-rays over here on the right. Nice joint space between the femur or thigh bone and tibia or shin bone. Nice joint space right here. This is a normal X-ray. A lot of times we'll see this with a focal cartilage lesion, and then we'll go ahead and proceed with an MRI. This is an MRI, specifically a T2 MRI. And on these MRIs, fluid is bright. Again, this is the femur or the thigh bone. The whole bone should be this dark color. It shouldn't have this brightness right here. These two arrows are pointing to two potholes, two areas of focal cartilage damage. The bone is seeing more stress because there's not any cushion there, and it's getting inflamed, and that's why it's bright or white on this MRI. Versus arthritis. So again, picture on the left of the damaged joint, picture on the right. Just from the X-rays, this is an obvious. We don't need an MRI on this patient. The X-ray clearly shows arthritis. This is what's called bone and bone appearance right here, where there's no space between the femur and the tibia. You go over here on the inside or medial side of the knee, it's also very narrow. There's osteophytes or bone spurs. The bone is also very white. We call that sclerosis. All signs of an arthritic knee, and the diagnosis is obvious. Just a quick aside, the shoulder can get arthritis, as well as the hip, or really any joint. This hip shows some mild arthritis on the left side. On the right hip, severe arthritis, there's flattening of the ball, or collapse we call it, and obvious, there's no joint space. Okay, let's get to the meat of this talk here, treatment options. So laundry list of different things we can do to treat or manage your symptoms with cartilage problems. I'm going to hit some highlights here next. Weight loss. The nice thing about the knee is it's up to a 4 to 5 times lever arm. So modest weight gain, which is bad, let's say 5 pounds, can increase the force on your knee by up to 25 pounds. Versus modest weight loss of only 5 pounds can take up to 25 pounds of force off your knee. All of our weight-bearing joints, hip, knee, and ankle, are very susceptible to increased symptoms with increased weight. If you are overweight, don't beat yourself up. That didn't cause your arthritis. This is a normal wear and tear phenomenon we all have. It just makes your symptoms worse the heavier you are. Smoking. Smoking is not good for our joints. I don't belabor this point. It's bad for lots of things, including your joints. So stop smoking if you're a smoker. Lifestyle modifications, specifically diets. So obviously, if you're overweight, you should be on a diet. There are some foods that have some anti-inflammatory properties. They're listed here. A common thing is olive oil. Instead of standard whatever oil you use olive oil. Whole grain breads, high fiber diet, high fruit and vegetable diet. Exercise and activity, very common question we get. People will say, oh, I have an arthritic knee, so it hurts to exercise. So yes, you shouldn't, if you have an arthritic knee, You should not be running, jumping on your knee. But there's lots of other things you can do exercise-wise other than running or jumping. Real quick, we know that exercise is a great thing, both physically and mentally, and those are tied together. There's an increased energy output with regular exercise, decreased stress, um, and you will strengthen the muscles that control your joint, which all helps control your symptoms. A little more specifics on exercise, specifically aerobic exercise. I tell everyone it's kind of like the old Nike commercial. If you remember that, just do it. A lot of patients will ask, oh, what's the best thing to do? And my answer is just do it. Just do something. It really doesn't matter. It can be walking, riding a bike, swimming, elliptical, Stairmaster. It really doesn't matter. You just want to avoid high impact activities, running and jumping. If you're not running or jumping, it's a great thing. Just go do it. Classes or personal trainers. We know if you go to a class or go to a personal trainer, you'll be more consistent with your exercise program. So highly consider that. Now, if you're self-motivated and you're going to work out 3 or 4 times a week on your own, that's great. But for a lot of people, having some accountability, either by going to a trainer or a class, helps them be more consistent with their program. Just some real brief examples on strengthening, just leg raises. So you can raise your leg laying on your back, you can raise your leg laying on your side or on your stomach. And they all strengthen your leg using different muscle groups. So you don't have to belong to a fancy gym to do strengthening exercises. You can also do wall squats. It's not shown on here, but you literally just put your back against a wall and lower your butt until you're bent about 45 degrees at your knee, and then hold it for as long as you can. Time yourself, do 3 sets. The next time you do it, try to beat your previous time. Easy way to strengthen your quads specifically without going to a gym. Medications, again, another common question we get. Tylenol is very, very safe and very, very underdosed for most people. The recommendation is a limit of 4,000 milligrams of Tylenol a day. I tell all my patients, let's stay safe at 3,000 milligrams a day, which is 2 extra strength, because the extra strengths are 500 milligram tablets. So you can take 2 extra strength Tylenol or 1,000 milligrams 3 times a day. In addition, you can also take anti-inflammatories. Common over-the-counter anti-inflammatories are Advil and Aleve. You can also get these prescribed by your doctor. NSAIDs are safety profile are not quite as safe as Tylenol, so you have to have precautions, specifically if you have stomach issues such as peptic ulcer disease, kidney problems. If you're on anticoagulants like Arixtra or Coumadin, you have to be very careful. Can't take NSAIDs. So this is something you should discuss with your doctor. And there's also chronic pain medications, which we'll touch real briefly kind of later. Other things you can do as a patient to take on your own. This is the kind of alternative treatment. Nutraceuticals, some people call them. Vitamins, herbs, supplements. Just real quickly about this. Arthritis is a very common problem. Basically, if you live long enough, you're going to have arthritis. The downside of that is there's a huge market for arthritis sufferers that we all are. And so there are a lot of people that will say this works and they'll sell it to you. And you have to be very careful on these things. The 2 of the things that have been studied the most are listed here, chondroitin and glucosamine. The doses are listed here. But even if you go to dosing regimens, you'll get the quotation that's listed there at the bottom of the screen. This product is a dietary supplement with no approved dosing. With that said, again, chondroitin and glucosamine, those are the doses most people take. Specifically about this, again, has been studied. Some studies show it may help long-term, but most studies show it does not. I tell all my patients there's no downside to taking these, as no one's shown any significant bad side effects from them, other than I tell everyone it thins your wallet. Some people don't like taking kind of these other things. I tell them you're not missing out on anything, because no one's shown that these make a big difference. and the long-term health of your knee. Okay, let's say you do all these things and you're still having symptoms. That's really the time to go see someone. If you're having persistent symptoms despite trying some things we mentioned, you should go get seen. Specific warning signs are really this locking or catching, swelling, other than pain, swelling and catching are the two things that get us excited that something, may be surgical, may be needed. If you see us or your primary care doctor, a lot of times we'll get other people involved, orthopedic surgeons like myself, sports medicine doctors, rheumatologists, PT/OT, a dietitian if you're overweight. Real quick on physical therapy, patients with arthritic knees that go to physical therapy do better than patients that don't go to physical therapy. A lot of patients will say, "Oh, I work out. Oh, I'm healthy. I do lots of things." But the studies are very clear. If you go to a supervised physical therapist with an arthritic knee, those patients head-to-head do significantly better than patients that don't go to physical therapy. So go to physical therapy. Again, if you see us, we're going to discuss medications. We've discussed already the Tylenol, the NSAIDs. Some patients have certain medical conditions or they're too old for surgery or whatever, and then we would consider chronic pain management. That can be narcotics, or there are other chronic pain medicines that aren't narcotics that can help control your symptoms without going to surgery. Injections, an exciting topic, especially now because of there's different types of injections we can do. And I'm going to go forward here, steroid, gel injections, and then the hot topic right now are the biologics or regenerative medicine, restorative medicine. Let me go backwards. Okay, cortisone or steroid injections. That's synonymous. Cortisone and steroids the same thing. It decreases the inflammation in any area we inject, specifically tonight the knee we're going to discuss. It leads to less swelling and pain. It is not a pain shot. Some patients will say, "Oh, I don't want steroid. That's just a pain shot." It does relieve pain, but it does it by getting to the root of the problem, which is inflammation. It decreases inflammation. It can last for months, sometimes even longer than 4 months. It's done throughout the country, thousands a day throughout the world. It is very, very safe. You can only get a few a year, and that's something to discuss with your physician, and it works. It's very effective, and we do it all the time, and it just works great. Then there's gel shots. This came out in the early 2000s. We thought this was going to be the best thing. It makes sense on paper. It's basically, I tell people it's like an oil change. Your joint fluid gets thin, gel makes it thick again. So theoretically, on paper, it sounds great. And we started doing it like crazy 20 years ago. And then we found out that even though it makes sense, it doesn't really work as good as steroid. And a lot of studies, it works less good, not as well as steroids. Sorry about my language. So a lot of people want this, and we tell them you can, but typically we start with steroid first. If steroid doesn't work, this is a good alternative, and in some patients, it actually does work very well. Okay, the latest topic, biologics, also known as regenerative medicine and restorative medicine. Very hot topic. It's basically biologics. We're using your own body to help restore or hold at bay the progression of your problem. Right now, there's 4 main types of biologics that we can do in the United States. Platelet-rich plasma, stem cells, adipose cells, and amniotic fluid. The 2 most common are at the top, PRP or platelet-rich plasma. What is that? Well, it's your own blood that we draw from you, just like a blood draw for labs. We then take your blood and put it in a centrifuge and spin it down, and then it layers out, and we get that platelet-rich plasma layer. Put that in a syringe and then inject it into your knee joint. The platelet-rich plasma layer in your blood is full of platelets, which are repair cells. They bring in all kinds of good enzymes and other factors that help repair damaged tissue. There's also stem cells. we derive stem cells from your bone marrow. So this is a bone marrow aspiration that we can do in the clinic. And similar to platelet-rich plasma, we draw it from you, we put it in a syringe, and then we inject it into your knee. Kind of emerging is adipose cells or fat cells. So basically, we do a mini liposuction, get some fat cells, and inject that into your knee joint. Just emerging right now is the amniotic fluid. So this is true amniotic fluid that is commercially prepared and sterilized that we can inject into your knee. Let me go a little more in depth here about the biologics. The theory is that these will alter the progression of your joint and maybe even reverse it. Very promising, kind of like gel that came out 20 years ago. It makes sense. The downside is currently there's no long-term studies. We've only been doing this for a few years. And it is very, very, very expensive. Insurance does not cover this. For example, PRP is about $500 to $600 per injection in your joint. Stem cells are about 4 times that, so around 2,000. And it depends on some things, but those are just approximate costs. That's a lot of money. So this is very lucrative. So again, this is kind of another beware thing for all of you here in the audience, is that we all have joint pain, especially we live long enough. And so you can shop around and find someone that will inject your knee with PRP or stem cells or something else. If you have significant arthritis, this will not help you. We know that. There's been studies, even though PRP hasn't been out that long, there are some clear studies. If you have significantly arthritic knee, PRP does not change that. It won't help you. It's not the fountain of youth. People may sell you on this, but just I would say, be very cautious and discuss with your physician about this and make sure it's indicated for you. Okay, let's say those things don't work. We tried some non-operative things with weight loss and strengthening. We've done some medications. We maybe done some injection, and you're still having symptoms. That's basically the indication for any surgery. It doesn't matter if it's orthopedics or anything else. We've tried non-operative things, and you're still having symptoms. Also, you have a new focal acute injury, that your knee was perfectly fine. You fell off a ladder or you jammed it playing sports, and now you have this pain and swelling in your joint, and we get an MRI, shows a focal cartilage lesion that usually equals surgery. If you see a surgeon, we will discuss this with you. What are your surgical options? For joint pain from cartilage in the knee, there's basically 3 things: arthroscopy, cartilage restoration, which is kind of under arthroscopy, and then joint replacement, when we basically give up and replace the joint. Okay, arthroscopic management. It's basically cleaning up the joint in very simplistic terms. We use small instruments about the size of a pen, typically 2 or 3 incisions around the knee. They're all 3 are about 1/4 of an inch long each, so very small incisions. We can clean the knee out. We can do a procedure called a microfracture. We can actually drill into the bone, and that gets your bone marrow cells or stem cells to kind of bleed into the joint, and a scab can form, and that can turn into cartilage. And that can be done very easily as an outpatient procedure. And that's really the good of arthroscopic surgery: minimally invasive, outpatient, quick recovery, minimal pain. So we love it. For the right patient, it's a great tool to use. The downside is it's not the treatment for arthritis. We know that if you scope arthritic knees, it may make the patient feel better for a couple of months, but in a matter of a few months, they'll be right back where they were because they still have arthritis. It's more for focal cartilage lesions, meniscus tears, best in more of the younger patient with symptoms less than a year, with new clicking, catching, popping, and they don't have significant arthritis, which means they have a good amount of joint space on their x-rays. Okay, cartilage restoration. So this is something I'm kind of near and dear to my heart. I've had specialized training in these 2 procedures. both MACI and osteochondral allograft. And we'll be done here in about probably 5 or 10 minutes before we get to the questions. So we're rounding the curve here. We're almost home. Okay, MACI. MACI is just an acronym for a membrane that has your chondrocytes, autologous chondrocytes. So your cartilage cells on a membrane that we put into the areas of your knee where there's some potholes, where there's focal areas of cartilage damage. This is a 2-step procedure, so it requires 2 surgeries. The first surgery, we scope your knee, so arthroscopic surgery, small incisions. We go in there, we see that there's a cartilage lesion amenable to this treatment. We go to an area of your knee and take some cartilage cells and we harvest them. We send them to a lab. They grow your cells on this membrane, and then we come back and then put them into your knee, into the area of the cartilage lesion. Right now in the United States, this is only indicated for patients less than 55 years old with a focal cartilage lesion. This is step 1. So this is a picture of a knee. It's got that focal cartilage lesion that we saw before. The rest of the cartilage looks good. Highlighted here in yellow are areas of the knee that cartilage is not needed, because primarily cartilage is needed on the weight-bearing surfaces at the end of the femur, so here and here, kind of centered. So we can go to the edge of the joint and take a tic-tac sized piece of cartilage and harvest that. And that's step 1. We then send that tic-tac sized a piece of cartilage to a lab, and they'll grow it on a membrane shown here on the left. And this is how it gets shipped back to us. So now this membrane is full of your cartilage cells that have been grown on this sheet. And then we take that patch basically and cut out whatever size your cartilage lesion is of that patch. And we put the patch into the knee. And now you have your own cartilage cells filling in that cartilage lesion. So now all your cartilage is basically back to normal. And that's called MACI, M-A-C-I. Another option is osteochondral allograft. This is basically an organ transplant, just like a kidney or heart transplant. We take someone else's tissue to fix yours. And this is basically a plug of bone with a cartilage cap is placed into your cartilage defect. This is an illustration of that. So over here on the left would be the donor bone. And we would go to your knee and see how big the lesion is. And this is somewhat elliptical lesion. This is round, but you get the point. We would measure the size that we need to replace yours. And we take a core of this cylinder graft, which is part bone and part cartilage, and then plug it into your knee. And now we have, basically brand new cartilage plug where you had your cartilage lesion. It's called an osteochondral allograft. Both of these procedures have pluses and minuses, but they're both excellent. Pluses and minuses in a sense that depending on the location of the knee, sometimes osteochondral allograft is better than MACI, and sometimes MACI is better than osteochondral allograft. But they both have excellent results. The vast majority of patients can return to their pre-injury level, to include high-impact sports. This is done in professional athletes, college athletes, high school athletes who do this all the time, and we get them back in the game. We get them back to their pre-injury level, and we've seen our athletes go on to higher levels of college and then professional sports after MACI and osteochondral allograft. So it's a great tool. It's the Cadillac or latest and greatest surgical treatment for articular cartilage lesions of the knee. And it's something we can, make a big difference in someone who has really a devastating problem. Lastly, we're ending up with a joint replacement. So this is when we give up, basically. I don't mean by giving up, but it's someone who we've tried everything. They have end-stage damage from arthritis, typically over 55 years old, but we can do total joints in patients younger than that. And they've failed non-operative measures, such as the things we talked about: weight loss, strengthening, medications by mouth, injections. When that happens, total joint replacement can be a game changer. We can take someone who's very miserable and can barely walk around the grocery store for 5 or 10 minutes, and they have to sit down because of their knee pain or hip pain, and replace that joint and getting it back to great function. Total knee replacements and partial knee replacements are very, very common procedures done throughout the United States and the world. You can do a partial knee replacement. So in this patient, their lateral joint or the outside of the knee has a nice joint space. They primarily have a problem just over here on the inside or the medial joint. So we can replace just the medial joint. This is called a uni, or sometimes called a partial knee replacement. And that has a little bit of advantages over total knee because you still maintain your ligaments. It's just less invasive surgery, kind of quicker recovery. This is more the younger patient with more focal osteoarthritis. There's also total knee replacement. So if you look over here on the left, there's also some narrowing lateral compartment. There's bone spurs over here. And this patient would do much better with a total knee replacement. And that is the salvage operation for anyone. So just real quickly in review, joints allow us freedom of motion. If they're healthy joints, we can run, we can jump, we can do whatever we want. If they're not, there's some things we can do to help you, both non-surgically and surgically. If you have persistent symptoms, come see us. And there's lots of different things we can do for you, both again, surgically and non-surgically. I think that's the end. Thank you very much for your attention, and we'll take some questions.
Okay, great. Well, as a reminder, if you'd like to ask a question, please type it into the Q&A, which you can find by hovering your cursor over the bottom of your Zoom window. We already have a couple questions. The first one is, I have degenerative changes in my knees that have worsened over the past few months, and cortisone gel injections help minimally. Are there other options other than a full knee replacement for me? And to add to that, I need to add that I have been diagnosed with arthritis, and my gait has been affected as to make my walk like Frankenstein. I teeter. My medical knee joints are compressing, though not bone on bone yet via X-ray.
Okay, and then Sarah, I'm sorry, what injections did they have? Did they say they had? The very beginning?
Cortisone and gel injections have helped minimally.
Oh, cortisone and gel. Okay, so so for injections, if it depends how bad your arthritis is, if you're bone on bone or significantly narrowed, injections are a good first start. And if you wanted to go all out on your injections, then you could consider doing a PRP. And then that would kind of round out everything that's been done injection-wise. Again, going back to the medications, if you're not taking Tylenol, you should be taking Tylenol. It's safe, it's cheap, it's easy to get. 1,000 milligrams 3 times a day. You should be on a strengthening program. You should be trying to lose some weight if you're heavy. If you haven't gone to physical therapy and you have a gait issue, you're walking like Frankenstein, physical therapy will definitely help you. If you've gone to all those things and you just want to be done with this, then it's just time for a knee replacement. If you haven't yet, I would definitely see an orthopedic surgeon and let them know you've tried cortisone, you've tried gel, you're still having symptoms, and she or he should be able to help you with setting up any things we just discussed.
Okay, next question. Is there anyone gel shots or cortisone shots would not work for? I had an X-ray and was said my knees are at a stage 4.
Okay. So stage 4 means you're bone on bone. So I'll give you a patient that I see regularly. She is in her 80s. She has some significant medical issues, and she does not want a total knee replacement. And so I see her a few times a year, uh, and either inject her knee with cortisone, steroid, or gel. Um, she still has symptoms. She still has bone and bone arthritis pretty bad, but her symptoms are a lot less by doing those injections. So even if you have stage 4 arthritis, we can still inject your knee and it can give you some relief. It is variable. Some patients can have horrible looking arthritis and they just do great with steroid injections. Other people not so bad and steroid doesn't help. But to answer your question specifically, there's no amount of arthritis that means you can't get a gel injection or you can't get a steroid injection. So it's always a good place to start, especially if you really, really, really don't want to have surgery. Or like I said, you're old, lots of medical problems, and or you don't want a total knee replacement, then we can just do periodic injections. It won't make your symptoms go to zero, but it can help.
Next question, what options are there for patients with a metal allergy?
Well, so it depends on the type of metal allergy. A lot of times we will get kind of into the weeds with that. So we'll get you in with an allergist. There are different metal implants they can use. And so there are some total joint options if you have a metal allergy. With that said, there are lots of things we can do, mentioned in this talk tonight, before we kind of give up on you and do a total joint replacement. So if you haven't, I would again see an orthopedic surgeon. And depending on how good or bad your arthritis is, go through the whole list of non-surgical treatment options. And then if that doesn't work, then you can discuss the specific type of joint that you can do in someone with a metal allergy.
Does Medicare cover MACI or allograft?
So good question. And I tell everyone I'm not an insurance specialist. Uh, but usually, if the indications medically are met, we can do MACI and osteochondral allograft. So yes, I have done those procedures in Medicare, Medicaid patients. With that said, every situation is unique. But in general, if you meet the indications for this, we will do whatever we need to do to get it approved. And usually we can.
Okay, and then is MACI good for someone with hardly any meniscus and arthritis?
Maybe is probably the right answer. So there's a little bit of a gray area. Ideally, we want someone who's, 22 years old and is the perfect weight, has the perfect joint with no meniscus tears, no other cartilage damage, just a focal cartilage lesion. And there are some of those patients out there, but there's other patients that are maybe a little older. They have some cartilage damage, some meniscus damage that we can still do the MACI procedure on. The indications are narrow, i.e. if you have a significant amount of cartilage damage or a significant amount of meniscus loss, then we probably would not be able to get that approved, or osteochondral allograft. So it is a little bit of a gray area. It just depends on how much cartilage damage you're talking about and how much meniscus damage you're talking about.
Okay, and then there's a question about whether the MACI procedure is covered by insurance, or what was the procedure that's not covered by insurance?
So of all the things we discussed tonight, everything that I mentioned is covered by insurance except PRP injections, which again are about $500 to $600. That can fluctuate, but around there. Stem cells are about 2,000. Those two things are the only things that I've discussed tonight that are not covered by insurance. The Macy procedure, osteochondral allografts are covered by insurance if you meet the indications. And again, that would be my job. If you came and saw me and you met the indications for one of those two procedures, then basically we would submit to your insurance company that we would like to do this procedure on you, that you meet the indications. And as long as you meet the indications, those procedures are covered.
Okay, next question. Do you have to have a certain BMI for surgery?
Again, kind of a gray area, depends on the surgery. The higher your BMI, the higher the risk of complications, and the higher the chance that whatever we do doesn't work or doesn't help you as much. So it depends on the specific procedure. For example, total knee replacement surgery. We like BMIs less than 30. That is not a hard number. There are plenty of patients in the United States that have BMIs greater than 30 to get their joints replaced. So it can happen, but weight loss significantly helps. Whether you've had a total knee replacement or not, whether you have a cartilage lesion or not, whether you have an Macy procedure or osteochondral allograft procedure or not, weight loss will significantly help your knee and your overall thing. And I know you've heard that before, but weight loss will help you, number one. And two, getting back to your question, there is not a specific BMI cutoff that's hard and fast. So it's, again, something you have to discuss with your doctor.
What do you think of knee braces?
So great question. Knee braces are kind of like, I was going to mention something else, but let me just, knee braces are about 50-50. Again, depending on the condition. So for example, you have an MCL sprain. You twisted your knee and you sprained your knee ligament. For sure, we're going to put you in a brace. Knee braces specifically are designed to protect ligaments. So if you have ligament damage, they work great. And we use them all the time. If you have joint pain from a cartilage lesion, in general, a brace is not going to do much for you because you still have your joint force going through the joint. Braces are mainly used to stabilize things. And so unless you have a ligament injury, then braces work. But if you don't have a ligament injury, it's kind of a 50-50 proposition. So for example, if I saw you had myotonic arthritis, I would discuss that with you. I would send you to PT. We would discuss the medicines, everything we've talked about again. And then I would tell you braces in your specific case of a cartilage problem are about 50-50. About half the patients, it helps them. It keeps the joint warm. It keeps it limber. It allows it to move easier. Other patients, it's too hot. It's too sticky. It's too tight. It bothers me. And so it's in general, about a 50-50 shot that it's going to help you. Just to follow into that, people will say, well, which brace? There's no magical brace out there. Whether it's made out of tin or copper or plastic or rubber, it doesn't matter. There's nothing magic about the material. The only magic is that it fits you well, that it's somewhat comfortable, like a shoe that you can put on and it fits you correctly. And it just basically gives some gentle warmth and kind of compressive support to the knee. And you can get this really anywhere. You can get it at a drugstore, you can get it online. If you saw us, we have a brace rep that's at our office kind of 24/7, well, 9 to 5, and we can fit you right there. And so it's a great question. I did not mention that tonight, but the bottom line is about a 50-50 shot that a brace will help you.
Okay, we have a couple knee replacement questions. How do you feel about digital printed replacement? How do you feel about digital printed knee replacements? And are there various grades of the replacements?
Great question. So the bottom line on that is that it's one of the most common surgical procedures done in the United States. That's good and bad. The good is there's multiple companies that make the prostheses, make the implants for us, and they're always trying to better themselves. You know, each company obviously wants to make money, so they want to have the best knee out there that we use to put into you. So almost, you know, every year there's something kind of new that comes out. So um, there's new implants coming out. There's custom made implants like you're discussing. There's new ways of putting in, for example, using the robot. And we think all of these things will make a long-term difference. What really comes down to with the total joint is how long is it going to last me? Because maybe 20, 30 years ago, there's a decent chance after 10 or 15 years, you may need a new total knee. Now, well over 90% of our patients get at least 20 years out of their knee. And majority of them take them, you know, their lifelong procedures. So getting back to your specific question, there hasn't been any long-term studies yet. You know, studies that have shown for, 20 years out that these all new special implants make a big difference. My general recommendation on that is you see someone who does total joints, and I would ask him or her how many they do a year. You want to see someone who does a lot of total joints, and then ask that physician what they use. Most total joint surgeons have a specific implant that they use, that they're comfortable with, that they've been doing for years and get excellent results. And I would implore you to more go with what the surgeon recommends than you going out and looking on the internet or talking to friends and say, hey, I want this specific total knee placed into me. Versus seeing a surgeon that is well-trained with good experience and good results, and let her or him tell you what they think the best implant is for you.
Okay, the next joint replacement question. When you discussed uni knee replacement, your example was close to bone on the inside of the knee. My x-ray showed close to bone on the outside, but the inside was still good. Is a partial knee replacement an option then?
Yes. Real quick on the partials versus totals. A lot of people will say, if you do a partial, you're doing it for arthritis, and we know arthritis doesn't affect just one side of your knee, and eventually the rest of your knee will get arthritis. So a lot of people will say, why do a partial? Because down the road, the arthritis most likely will progress to the rest of your knee, so why not just do a total? So that's, again, a discussion. I'm not trying to pass the buck here. Again, it's a discussion you have with your total joint doctor. But yes, you can have a partial knee replacement for a lateral sided disease like you have.
Okay, I am 66 and have been diagnosed with bone-on-bone arthritis. I am considering knee replacement. Do you recommend pre-surgery physical therapy to better prepare for surgery?
Yes. Yeah. We know, I kind of tell all my patients, the stronger you are, the more flexible you are going in, the stronger and more flexible you are coming out after the surgery. So you don't have to go, 50 visits to PT. You may just go once or twice. The physical therapist gives you a good program to do, and you do it on your own. But yes, that is a very good thing to do if you have that luxury of getting that some pre-joint physical therapy. That is a great idea, yes.
Next question. I was told my knee is bone-on-bone per x-ray. I have more side-to-side pain. They have me on meloxicam for pain. I haven't tried any of these other options you suggested. I am 55 and want to be more active. What is my best option?
So it depends on how bad your symptoms are. So, for example, I'll have plenty of patients in their 50s that have pretty severe arthritis. So their x rays look really bad, but they still respond to all these measures. So, for sure, right off the bat, I would say take Tylenol, 1,000 milligrams 3 times a day. You can take that with Mobic. Real briefly, I should have mentioned this earlier about Tylenol and the anti-inflammatories. You do not need to alternate them. That is an old wives' tale. Tylenol and anti-inflammatories are broken down differently. If, for example, you're taking Mobic, which is you take either once a day or twice a day, depending on your dose, you can take, for example, your Mobic in the morning with 1,000 milligrams of Tylenol, at lunchtime 1,000 milligrams of Tylenol, and then at dinner 1,000 milligrams of Tylenol. And if you take Mobic twice a day, you can take it right then as well. You don't have to alternate it. So add Tylenol. Make sure you're on a strengthening program, if you can, a physical therapy directed strengthening program. Injections, and patients that are in their kind of younger, in their 50s like you, are people we really try, if we can, to hold off on a joint replacement by trying all those things I just mentioned. So I'm 54, and if I have what you have, I would Tylenol. Mobic is a great, safe anti-inflammatory. For sure, I would try at least a steroid injection. If that didn't work, I would definitely consider a gel injection and or PRP. And so I would do all those things first. And then I would just kind of assess how I'm doing. If it controlled my symptoms enough, I can do all the activities I wanted to do, then just hold off on a total knee replacement. Just kind of keep doing everything you want. The nice thing about arthritic knees is there's no rush to a total joint replacement, because a total joint replacement is the same operation no matter how good or bad your arthritis is. We're just replacing the joint. So there's no rush or benefit to early total knee replacement, other than it just gets you over your symptoms. The point is, if you're 55, go as long as you can. And if your knee isn't too painful, it's not too stiff, you can still do the things you want to do, then consider all those things we kind of mentioned tonight, to help kind of basically bide you time and allow you to do everything you want to do before you kind of give up and have a total knee.
Okay, the next two questions are on recovery time. What is the typical recovery time if you do have a total knee replacement? And then what is the recovery time for MACI?
So let me get back to MACI, because that's what I do more of. So MACI is a 2-step procedure. So again, 2 surgeries. Step 1 is we do the biopsy. Step 2, after they've grown the cells on the membrane, they send it back to us, and we go back in and implant that into your knee. Recovery time is, again, a very common question we get asked. It just depends on what you mean by recovery. So for MACI, for example, same day for surgery, we do the surgery, you go home, you're on crutches for about 6 weeks. Kind of week by week, you're putting more and more weight on your knee. By the time you're 6 weeks out or so, and this can vary a little bit, but after 6 weeks, you're off your crutches. Now you're a normal person walking around, but you're not doing any kind of heavy running or jumping. And then a few months out, we get much more aggressive with range of motion and strengthening, and doing everything except running or jumping. And then you begin running 4 or 5 months out, and then return to sport, a few months after that. Total knee is a little bit different, because someone with a total knee is not going to get back to running and jumping sports. Because if you do a total knee, you can't really do lots of impact aerobics on a total knee. I tell everyone, after a total knee, you go from being a singles tennis player to a doubles tennis player. Doubles tennis, you kind of just stay in your half of the court, and you kind of go a little side to side, a little front and back, but you're not really going real hard. But you can bike, you can hike, you can swim with the total knee, you can golf, you can do just about anything except heavy kind of running, jumping, pounding on it. Specifically, getting to your question, you're on crutches or a walker for about 4 weeks after a total knee. After about 4 weeks, you're off most ambulation devices, normal person walking around. And was back to the point that you're kind of back to normal, so to speak, and you can go do doubles tennis or unlimited hiking or swimming or biking. That's typically around 3 months out.
What is the success rate for a total knee replacement?
So probably the best way to answer that is revision rate and complication rate. So revision rate means what's the percent chance that it has to be done again. So right now, current day and age, if you meet the indications for a total knee without significant other medical issues, there is, well over 90% chance your knee will last well over 20 years, if not, again, the rest of your life. So at least 90% chance you can get at least 20 years out of your total knee. Downside to total knees, they're big operations. So unfortunately, some bad things can happen. About 2%, plus or minus a little bit, will get the two major complications we worry about with the total knee, and that's a significant blood clot or a DVT, or an infection that sometimes requires a redo operation. So the 2% chance of something very bad happening. Real quickly on total joints, of all the procedures we do in orthopedics, it's almost the biggest delta or the biggest change that people get from how they felt before surgery versus how they felt after. So there's a significant jump of an improvement after a total knee. So it's a very successful operation. Again, 90% get at least 20 years, and only a very few small percentage have a very bad outcome.
Okay, we have just 3 questions left. So
Okay.
I guess this is a last call for questions. If you'd like
Okay.
to enter questions into the Q&A box. So is PRP an option for someone in their 60s?
Yes, absolutely. As I was mentioned earlier, there's no age limit or arthritis limit on who can get injections. You can be 95 years old and we can inject your knee with whatever you want us to inject it with. There is a correlation, however. The worse your arthritis is, the less likely steroid, gel, or PRP will help you. If you're someone that's not just, I don't want surgery, then we'll just keep injecting you as long as it keeps helping you. So to answer your question, there's no age limit. And also remember, we are always looking for something better to inject. So there's other things that are coming. The adipose injections that I mentioned, amniotic fluid is available right now. Everyone, in the United States is trying to figure out which patients to do the amniotic fluid injections in or the adipose injections. So there's all these other biologics that, if we did this talk a year from now, there'd probably be something else out there. So the point is that don't give up. Go and discuss it with your doctor, and yes, you can have PRP if that's what you like.
Do studies show that a vegan diet helps with arthritis?
Some studies do, some studies don't. We'll just put it to that way. I would just, for sure, that people, if you're a vegan, that means most likely you are a very healthy eater. And yes, that is a good thing to probably answer your question directly. I'm not a vegan, and no offense to anyone who is a vegan, but I do try to eat healthy, high fiber diet, fruits and vegetables, multivitamins. So you don't have to be a vegan to make your knee better. But for sure, a healthy diet, and vegans may have a little bit of a leg up compared to other people.
Okay, I had a total knee replacement and a revision. Now the revision is loose. What is the risk for a third replacement?
Um, well, every time you have a revision, so the best results, let me back up. The best results for total knee replacement are what we call primaries, or someone who's never had previous or previous joint replacement surgery, and we put in a new total joint for them. That's called a primary, we call it, and that has the highest success rate. Every time your total joint needs to be revised, your success starts to drop even lower and lower and lower. So for every revision you have, there's a slightly higher chance to having another revision. I would just highly encourage you, if you've had a revision total knee and it's still bothering you, that for sure, you see a total joint specialist. So I would implore you that you see a surgeon who's been fellowship trained in total joint replacement, and you can ask them, or you can go to their website and look at them. It should say you should see fellowship trained in total joint replacement. If you don't see that, I would recommend strongly that you see a surgeon who's been fellowship trained in total joint replacement.
Okay, and then last question, would you recommend getting a second opinion if therapy and injections have been unsuccessful and there is hesitation for surgery due to my age? I am 51.
Well, I tell all my patients, there's nothing wrong with getting a second opinion, and I tell everyone I understand that. If I take my car to the auto shop, I don't know the mechanic. I don't know what they're doing back there. They can come out and say, "Gosh, we have all this stuff wrong, and it's going to be $5,000," and I have to go, "Okay." So I understand that, and most surgeons understand that surgery is a big deal, and most of us have thick enough skin that we don't mind at all that someone gets a second opinion. So there's really no downside to getting a second opinion, other than the cost, obviously. So it's never wrong to get a second opinion. And if your surgeon is upset or whatever about that second opinion, then that's on him or her. So I would never hesitate about getting a second opinion. Now, getting to you specifically, so you're in your 50s, you're a little on the young side to get a total joint, but if you've done non-operative measures, such as, again, everything we've listed tonight, the Tylenol, the weight loss, the strengthening, you've done some injections, and you're still having symptoms that are affecting your life, and I just tell my patients, if you're unhappy because of your knee pain, despite everything we've done non-operatively, that is the indication to have a total joint. And it's okay to get a total knee in your young 50s if everything else has failed. But don't worry about getting a second opinion. And if you're young, I would get one, yes.
Okay, thank you, Dr. Fester, for your informative presentation. We appreciate your time and expertise. And I want to thank you so much for joining us this evening. I hope that you have found the information shared useful. We feel privileged to be with you tonight and hope that you consider us for any healthcare needs you may have. If you'd like to learn more about Dr. Fester or his practice, Premier Orthopedics, you can visit premierorthooh.com. More information about Dr. Fester can also be found on his bio that was sent along with the information to access tonight's event. Should you have additional questions or would like to make an appointment, his office phone number is on both the practice website and on his bio.